Hello? Collins, can you hear me?
I can hear you.
Oh, thank you. I should have said mic check 1, 2.
Jonathan.
Hi, Nora, how are you?
Fine, thank you. Good to hear from you.
Niko salama, labda wewe.
Niko poa tu.
Good.
Okay, so currently we have 378. So we are waiting for people to join. Then I think once we reach 500, I'll be sharing the live link for the rest of the people who will be joining by YouTube.
Okay.
I've allowed also, you can use your videos. So your videos are on. So if you feel like you want to present using your video for the people who will be joining via YouTube to see you, so you can also enable your video.
Okay, Jonathan, what do you think?
I think I'm fine this way.
Okay.
So Collins, do we have is Mary around?
I'll try and get a hold of her. I'm not sure
Okay.
whether she's around.
Oh, so I was wondering whether there will be somebody from NASCOP to open the meeting.
Just a minute. No, currently I'm not sure there'll be someone from NASCOP. So we'll just start the meeting. You can just continue. We have been given the go-ahead to continue the meeting.
Okay. Okay. Jonathan, are you getting me?
Yes, Nora, I can hear you loud and clear.
Yeah, I was wondering whether you could generally open and welcome me as a first presenter.
Sure, not a problem.
Nora?
Yes.
You can hear me?
Yes.
So what I'll just do, I'll basically start the meeting off. Then
Okay.
now Jonathan will take over, and then we'll introduce you so that you can now take over the meeting.
Okay. Great. Thank you.
Okay.
Hi, Nora, Collins, Jonathan. Sorry, I've been a bit mute. I've been trying to reach out to Mary on the side.
Great. So, hi, Samson.
Good to hear from you. Thanks for coming on board well in time.
Good. So probably since you are around, you may welcome us introduce us to start the training. I was talking with Jonathan that he could welcome me. But since you are around, you can, after the NASCOP, I don't know his name, open the meeting. Collins, open the meeting. Introduce me and Jonathan, and then ask me to start off.
Great, I'll be happy to do that. Thank you.
Thanks, Samson.
Thank you.
Video. Good afternoon, everyone. I hope you can hear me.
We can hear you.
Good afternoon, everyone, and welcome to this session for the HTS guidelines continuation as we go ahead with the refresher package that we are offering to the HTS providers. My name is Mary Mugambi. I'm reporting here live from Gillian Hotel. We're in another prep meeting. And just to welcome every participant from all the 47 counties to this meeting, that you're going to be learning a lot in regards to HTS. We are also live on YouTube. I note here that we have 508 participants, but on YouTube, we can be able to accommodate much more. Karibuni wote. So today we are going to be having various topics, and the most interesting topic of all, assisted partner notification services, how to offer our services to our healthcare providers using APNS. As you know, at NASCOP, we've been able to focus more on strategic testing and not just general testing as the epidemic keeps changing. I would like to thank the NASCOP team, the Clinton Health team as well, more so the CDC team and USAID, who have been able to facilitate this training. Today, we are joined by Dr. Jonathan and Dr. Nora Talam, who will be taking us through the assisted partner notification services. So karibuni, and feel free to ask questions. You can ask some questions on the chat, and we have a team that will be taking the questions from YouTube and asking them live here. Asanteni, and back to you, Jonathan. I'll hand over to Dr. Jonathan Mwangi of CDC, who is the HTS lead. Dr. Jonathan, over to you.
Thank you. Thank you very much, Mary, for the warm welcome this afternoon. I don't know what the weather is in Julian, Chacos, but it's a nice warm afternoon here in Nairobi. So I'll be co-hosting the session today with Nora Talam, as you've said. So Nora will go first, then I will proceed after her. To everyone, my name is Jonathan Mwangi with CDC, where I serve as the technical lead for HTS. So without much further ado, I wish to hand over to Nora Talam to take us through. Nora.
Thank you so much, Dr. Mwangi, and thank you so much, Mary, for welcoming me. My name is Dr. Nora Talam. I work with BOD, PEPA program, based in South Rift Valley. I lead the HIV prevention programs. So at this particular time, I'll be taking us through the first part of the APNS, and I want to welcome all of us for this interesting session. And I know at the end of the training, we'll have a number of questions on this particular topic. So I want to share the screen so that I start off with the presentation. So I hope you're able to see my screen.
Yes, we can.
Sure. So sorry, I'm trying to. So I will start on the spot to take us through assisted partner notification services as part of the package of ATS, as part of the targeted intervention. And we all know that we've come quite a long way in ATS programming in Kenya. So at this particular time as a country, we have actually managed to really look at the best strategies based on the various trials that has been done outside and within the country that inform best way of case identification as you optimize ATS services. So part of those ATS strategy, which is actually quite yielding, is what's called assisted partner notification services. So I welcome all of us for this training. So I'll do the introduction to partner notification services. So first of all, we need to understand what's all about partner notification services. So partner notification services is actually a contact kind of tracing. It's contact tracing, the way we have been actually doing contact tracing when it comes to STI. So it's a kind of a voluntary process where we have a trained provider or healthcare worker asking people who have been diagnosed with HIV about their sexual partners or the drug injecting partners, and with the consent of this particular clan, they reach out to their partners so at least they can actually offer voluntary HIV testing services. So PNS actually focuses mainly on testing individuals who may have been exposed to HIV and probably they are not aware. That's why today we'll actually get to understand much better way of improving or implementing the partner notification services in a way to really help in case identification. So when it comes to partner notification services, which are voluntary process, it normally has two types. We have what's called passive partner notification services. Then we do have what's called assisted partner notification services. So I'll unpack each one of them so that we all understand. So when it comes to passive HIV partner notification services, it's actually a process where when we have HIV positive clans who are actually encouraged by a provider to disclose their HIV status to their sexual partner and or to drug injecting partners by themselves. And through this way, they're actually supposed to suggest HIV testing services to the partners, given that their potential of exposure of HIV infection. So when you have a newly diagnosed individual, for example, they are actually they are encouraged by ATS provider to really reach out to the sexual partner or drug injecting partner, so at least they suggest the importance of ATS service provision, given that the partner in question could have been exposed to HIV infection. So what about the assisted partner notification services? So when we talk about assisted partner notification services, it's a voluntary process where we have a consenting HIV positive clans are assisted by a trained provider to elicit their sexual partners, to list the sexual partners or drug injecting partners and notify them of their potential exposure to HIV infection with an aim of offering them ATS services. So when we have a clan, HIV positive clan, they're actually encouraged to elicit the sexual partners by this trained provider. So at least because these sexual partners in a way could have been exposed to HIV. So it's actually aimed at supporting a clan who has turned out to be positive, which is an index case, to reach out to all the sexual partners and actually with the aim of providing ATS services because of the exposure of it to HIV infections. So the clans in this case are empowered. You know, there's power when it comes to knowledge. So the clans are empowered or assisted to disclose their HIV status to their partners. Now, there are several options of notifying a partner about HIV testing services. So we have 4 methods of notifying the sexual partners about HIV testing services. So we have what's called clan referral, we have provider referral, we have contract referral, then we have dual referral. So when it comes to clan referral, this way you tell a partner about the HIV status and encourage that clan to come to the health facility for an HIV test. So when you have a clan actually who is HIV positive, try to reach out to the partner. And they reach out to partner about HIV status, encourage the partner actually to come to facility for an HIV test. Then when it comes to provider referral, This is where we have a counselor or a trained provider, healthcare provider, who actually call or visit a partner and inform the partner in question about the need to have tests to HIV because of possible exposure. Then we have what's called contract referral. This is where we have both the provider and the clan or the Hts provider who work together to notify the partner in question. This is where we have, like, they give a room around 30 days to tell the partner, the clan is given around 30 days to tell the sexual partner about the case. Then after which we have the counselor chipping in to actually help in conducting the partner. Then we come to dual referral. This is where we have the counselor or the provider will sit in with the clan and the sexual partner and support the clan in actually doing a disclosure with the partner. So the various four methods I have discussed here is actually arrived at based on discussion between the healthcare provider and the clan. In this case, we stand out to be positive. So what worked best will actually be informed by the index case, who is actually HIV positive, or what work based on the various sexual partners that they have. So if the clan referral, they imagine that the clan in question will be able to tell the partner, that is well and good because they understand best their sexual partner. If they require the support where they will sit together, then we have the dual referral. Then it depends on what works. So these are the four methods of reaching out or notifying the sexual partner about HIV testing services. Now, I will actually define here. I've talked about index clan, I've talked about index testing. What do these terms mean? Index clan, in this case, is an individual who is newly diagnosed or HIV positive and or an HIV positive clan or individual who may or may not be enrolled in HIV treatment services. So it's a newly diagnosed individual who is HIV positive, or the clan in question is HIV positive and may not have been enrolled into treatment. That's what's called index clan. Now, index testing is a voluntary process. It's a process where we have the counselor or the healthcare workers asking the index clans to list all the sexual partners or injecting drug partners within the past 1 year. There's a reason why there is a period of 1 year based on the various studies that have been done across the world, and also children and also other partners. So we have the voluntary process. We have the counselor and healthcare workers asking the index clan to list all their sexual partners and also the children and over them HTS services. Now, I want us to understand sexual partners and also what it means by elicitation of partners. So sexual partners in this case is individuals who may have any form of sex, whether vaginal or anal or oral sex with an index clan. These include casual or static sexual partners. Now, when it comes to elicitation of partners, this is reversed to listing of all the sexual and or drug injecting partners of an index clan. So in this case, we have the index clan actually after being talked to is able to elicit the contacts of all the sexual clans or the sexual partners or the drug injecting partners of index clan in this case. So they're able to list, so that at least they can be reached out using various methods on what works to come for HTS services. So what is the aim of all partner notification services? The main objective of partner notification services is to break the chain of HIV transmission by offering HTS to persons who have been exposed to HIV and also link them to care and treatment or link them to HIV prevention services, depending on the outcome of HTS services. So it secondly optimizes case identification. They also give opportunity to people who could actually be exposed and they are not aware that they are HIV positive, and also fast enrollment of this clan to care and treatment by actually optimizing linkage services. And also, if they are negative, they actually are linked to HIV prevention services, so at least the transmission is actually cut. So it's actually a all-round kind of strategy which aim at optimizing HTS services and for better quality life for the clans. So what is the rationale? Why all these assistant partner notification services? So assistant partner notification services increases uptake of HTS among sexual partners of HIV positive clans, and therefore it results in a high proportion of HIV diagnosis and linkage to care and treatment. You know, as a country, we have been quite struggling in terms of case identification. So we've been trying to put pieces together in terms of optimizing case identification. Once we have identified, we need to link all of them to care and treatment. So we are also optimizing linkage to care and treatment. And therefore, we have all those who have been identified being put on ART. And therefore, we actually, when everybody's on ART and track adherence 100%, we actually reduce transmission to minimum level. That's the rationale behind the assisted partner notification services. So we want to understand what is justification for APNS. What is justification for APNS? And you know, when it comes to justification, we really base on data. So we actually look at this slide is showing us global statistics on what we are actually learning from 2019 global statistics. So we are able to see that in 2019, we had 38 million people globally living with HIV, 38 million people living with HIV. Out of that, 25.4 million people were actually accessing ARVs. However, we had 1.7 million people becoming newly infected with HIV, and there could be so many reasons. We'll actually discuss that in the next slide. And then we have 690,000 people who died from AIDS-related illness. So we are able to see this, the map here. We're able to see that from this map, the one showing the dark blue, is showing that in the southern and eastern Africa, we have highest disease burden, the dark part, from the map that we are seeing here. That's why there is really need to focus more on optimizing ATS services in this particular region so that we reduce infections. Now, so there's what is called Global 90-90-90. So based on what we have understood about challenges that we are facing as a country, this UNAID 90-90-90 was actually brought about, it's actually a kind of ambitious targets so that at least we try as much as possible to minimize transmission. So the first 90 is actually telling us that 90% of all people living with HIV need to know their HIV status. For all the people who are living with HIV, 90% of them need to know their status. Then out of those who have known their status, 90% of them will need to receive ARV. And out of those who are on treatment, in this case, 90% of them will need to actually have viral suppression. So if we can have this achieved as a country, I'm telling you, we'll have a reduced transmission rate, because if everybody who is on treatment have viral suppression, then transmission will be quite minimal. So we need as a country to really see how far we are in terms of reaching out to 90-90-90 ambitious targets, so at least as a country we try to reduce infection rates and actually realize epidemic control. Now, I want us here to see the global progress when it comes to 90-90-90 targets. How far are we globally? So globally, we are able to see data there that, remember, there were 38 million people living with HIV globally, but that 30% of whom do not know their HIV status. They are HIV status, but they are actually HIV positive, but they are not aware that they are actually HIV status. So based on 90-90-90, we are able to see that 90% of people who are living with HIV need to be aware that they are HIV positive. And out of this, we should actually have 90% of those who are HIV positive should be on treatment. And out of those who are on treatment, we should actually have 90% of them being viral suppressed. So if we can optimize this, we'll actually have 30 million people on treatment. Remember, we only have less than, we have around 25 million people on ARVs. But if you optimize the 90-90-90 cascade, we'll have most of the people actually having around 30 million of them being on treatment. And then what does it mean when it comes to viral suppression? It means we'll have fewer than 500,000 new HIV infection annually. And remember, from the previous slide, we had around 1.7 million people who are actually positive, but they are not aware that they are positive. So if we can optimize 90-90-90 cascade across the world, we'll be able to actually have reduction in terms of infection. Now, this is actually showing us the UNAIDS 90-90 targets for Kenya. Now we are skewing to our country. Let's see how we are faring as a country. This slide is showing us the 90-90 cascade across the various age bands. The first one is showing us 0 to 64 years, how far are we faring when it comes to Kenya 2018. Then the age band of 15 to 64, how did you fare across the 90-90-90 cascade? Then 0 to 14, where are we as a country? So starting with the first 0 to 64, like everybody. So we have 79.4% of people living with HIV get to know that they are actually HIV positive, or their caregivers get to know the HIV status of their children. Then out of this, we had 95.7% of them who are actually put on ART, 95.7%, which was quite good as a country. That is KenFIA 2018. Then 88.4% of people actually on treatment actually had viral suppression. We are charged about some few points to 90% mark. So when we unpack data now to other age bands, like now 15 to 64-year-old, let's see how we fared as a country based on KenFIA 2018. So we have 79.5% of all the people who are actually HIV positive get to understand or know that they are HIV positive, that's 79.5%, but based on sex, we have more female get to know much, as 82% get to know their HIV status compared to male, which is again 72%. Then in the second 90, we have 96% of them who are actually identified were put on ART. When you unpack based on sex, we have 96% female and then 94.5% male. Now, when it comes to third 90, we have 90.6% were virally suppressed. That means female were 90.4%, male were 90.9%, fairly good. Now we have a challenge when it comes to pediatric. From 0 to 14, we were able to have 78.9% of the children getting to know their HIV status through their caregivers, known to their caregivers. Then out of this, who got to know the caregivers got to know their HIV status, and 3.2% were put on ART, which is good. At least 93% of them were put on ART. What about the third 90? Only 67.1% of the children on treatment had viral suppression. So there's a pickup from the viral suppression, and also a fairly pickup when it comes to identification for children. So this is actually giving us ideas that we are not doing well when it comes to identifying the children and also viral suppression for the children. So when you look at the children generally, we look at the various studies that have been done, you find that children are lacking behind in terms of drug adherence, either clinical appointments, taking drugs from the pharmacy, timely taking of the drugs. And when you look at the measures of adherence, like CD4 counts, viral loads, they're actually not good. So there's something that we need to do as a country. So this data is showing us performance among people living with HIV, which was based on self or caregiver reported knowledge of HIV status and ART, but was adjusted based on lab detection of ART in their blood. So it's actually quite informative kind of data from KenFIA 2018. Now this slide shows us HIV testing and treatment cascade in Eastern and Southern Africa. Why Eastern and Southern Africa? We realized based on the map that we saw that the Eastern and Southern Africa have high disease burden. So in this case, we want us to see the case identification or HIV testing and treatment cascade in the Southern and Eastern Africa. So the first one is showing us the number of people living with HIV, actually, and then we have the percent. So we are able to see from the first 90, 76% of the people get to know their HIV status. So we have a cap in the first 90 of 2.7 million people who are not aware. A big challenge. And then when it comes to second 90, only 60% of those who are identified were put on ART. There's a big gap there shown in the second 90 of 4.1 million people. What do we do as a country, as a region? That's why we are discussing there about strategies that can improve case identification. Then we have 50% of those who are on ART who actually have viral suppression. So the third 90 has a cap of 4.5 million people who are not virally suppressed. So out of 2.7 million people need to be tested. That's a big cap. And linked to care treatment in East and Southern Africa by 2020. It's actually the UN8 2016. Now, let's see the progress to 1990 when it comes to Kenya adults. This is actually adult cascade. Now, when it comes to the first 90, 79.5% of people who are living with HIV were diagnosed with HIV in the first 90, that's case identification. Out of this, 96% of them were put on treatment. And then out of those who are on treatment, we have 90.6% were virally suppressed. So this is actually data which was put under 95% what we call, we have the data was actually done to show the various caps from the first 90, second, and third 90. So at least as a country, as a region, we plan with the best way possible to actually fill the various caps. Now, this slide is showing us HIV testing and positivity. This data which was collected in the country from 2012 to 2018. So what does this slide show us? So we are at the extreme right, we have number of HIV tests which was conducted in this country. And then on the extreme right, we have positivity. And then we have down there from 2012 to 2018. This is showing us that we are seeing a reduction in positivity over time from 2012 to 2018. What does it mean? As a country try actually almost reaching epidemic control, we have case identification, the yields become reduced every now and then. What does it mean? It means that we have to do much better in terms of being smart in targeted testing so that at least you optimize identification. And of course, look at optimize PITC because that's why we always have high as the testing volumes in all the facilities. So as a country, we have to really work hard in terms of optimizing ATS services, right from the targeting, right from case identification, so that at least we're able to do targeted testing. We are able to use high yielding strategies that are able to really identify. We are able to optimize eligibility screening in the OPD so that at least we actually optimize identification. So you are able to see that as the country nears epidemic control based on that data from 2012 to 2018, we find the yields are quite low. That means we need to do my targeted testing so that at least we don't leave anybody outside there without being identified. Now, this one is showing the ATS, the first 95 testing cap in Kenya. That's actually based on KenFIA 2018. So what does this slide tell us? So in Kenya, we have about estimated about 1.5 million people living with HIV. So based on the KenFIA 2018, 79.4% were identified, meaning there's a cap which was left around 10.6% to reach 90% mark. So what does it mean? This means to close the cap on the first 95, we need to identify and link additional 330,000 people through innovative but targeted ATS strategies, which include in this case PNS, among others, including optimized PITC and also social network strategy, among others. So today we are looking at the PNS. So this slide shows us partner notification as an effective case finding strategy. So this slide shows us that this strategy has been tried across the world. So we have several studies which have been done. These are several trials that demonstrate that PNS can increase uptake of ATS and also identify partners with undiagnosed infection. And based on the various studies which have been shown there, the yields ranges from 35 to 62%. And there is no much reports on serious intimate partner violation based on the studies which have been done across the world. Like the first one was done in Tanzania. Then we have the second one, which was done in Malawi. We have down there, we have the one which was done, in Cameroon. And then when we also have down there, the one which was done in Sub-Saharan Africa. And we also have the one which was done in Kenya, the effectiveness of PNS services for HIV in Kenya, a clustered randomized trial, which was done by Peter Cherotich et al. And the results were also giving the same information that PNS work. But at least there's need to really see how to really package and actually have it implemented in our country so that at least we are able to increase case identification and realize epidemic control. So this is also another slide showing the publication which has been done. Like we have the implementation science where we have the assisted partner notification services to augment HIV testing and linkage to care and treatment, which is a protocol for cluster randomized trial. We also have another one, which was assisted partner services for HIV in Kenya, a cluster randomized controlled trial, which has been published there also in Kenya by Cherotich et al. Then also understanding the barriers to scaling up HIV assisted partner services in Kenya. So these are some of the publications that you can download and read in detail and understand how this concept were actually implemented in the country and how we can do much better in case identification through APNS. Now, so this slide is actually showing us effectiveness of APNS on HIV in Kenya, a cluster randomized trial. This is I can explain, I'm not going to detail. So in Kenya, we had it conducted between 2013 and 2015. And it was done in 18 rural and urban centers in central and western Kenya. How the site was selected was based on the PIs and the study team who actually conducted this. And we had two arms of the study, the immediate, the intervention arm where immediate APNS was done. Then we have the control arm, which was at late APNS by 6 weeks. The results were actually interesting. We had partner notification rates increased by 4 times, fourfold, based on the results. And then rates of first-time HIV testing among men increased by 11%, 11 times. And then the rates of testing for HIV positive increased by 3-fold. If it was 2, we actually have 3 times on what they used to get before as a country. And the rate of those enrolled in HIV care treatment also increased by 4-fold. And there are no intimate partner violation cases attributed to intervention. This was a study which was conducted in the country in those areas which are shown in that particular map. Why are we focusing on social partners in this case? So it is the main mode of HIV transmission, which is actually heterosexual. And in Sub-Saharan Africa, we have 70% of all incidents of HIV infection being through heterosexual, which is actually sexual transmission. Secondly, there's a significant proportion of individuals who are unaware of HIV status. So these PNS, sexual partner notification services, actually help in terms of the sexual partners of HIV individuals who are actually at high risk of getting infection if they are not aware that their partners are HIV positive. So this slide is actually showing us why are we focusing on index testing. So the benefits of index testing are in 3 folds. 1, we look at benefits to the index clan. We look at the benefits to the partners and the children, in this case of index clan. And thirdly, we look at the benefits in terms of community. When it comes to index clan, the benefits to index clan or individual level, it provides support to people living with HIV to assist them in getting their partners and children to test for HIV in this case. So it really helps all people living with HIV to actually get their sexual partners and the children to test for HIV. And then 2, it also takes the owners of the index clan as a sole person responsible for notification. So the index clan in this case is also supported to notify the sexual partners. It also actually provides timely access to ART in this case and provide, of course, quality life to the individual in question. And in this case also to the individual, it improves, of course, adherence because we talk to the clans earlier now, we talk to the clans well, it can improve adherence, it can also improve retention in treatment so at least we have optimum care and services of this particular clan. And of course, it also increases access to prevention options in this particular case. So in this case, it also empowers the clan, this is clan empowerment. And of course, enhances support to those not ready to notify the sexual partners. So what are the benefits to the partners and the children in this case? The partners, the sexual partners and children of index clan. 1, it maximizes the proportion of partners, children who are actually notified of their exposure to HIV. Then 2, it allows HIV exposed partners and children to get tested for HIV. Thirdly, it also allows HIV partners and children to access HIV treatment to reduce related disease and mortality. So we are able to see that the benefits of our sexual partners or children of the index clan are benefiting from actually index testing because it actually provides mutual support to access HIV prevention and treatment and care services for the clan in question. And of course, it also improves support to PMTCT program. In this case, it also improves the support to PMTCT if the class actually is actually having a challenge. And of course, it helps in terms of prioritizing effective HIV prevention of sexual zero-discontent couples, so at least they can access like condoms, ART, PrEP for prevention and for actually for the negative partner. So what are the benefits when it comes to the population or the community in this case? So if a community is an effective case finding strategy, it actually reduces future rates of transmission by aiding in early diagnosis, of course, and treatment partners and children found to be HIV positive. And of course, it reduces HIV transmission in the community. You know, now it becomes a public health intervention. It's a highly skilled public health intervention. So it reduces HIV transmission and of course, increased number of people on ART or pass on ART in the community, and of course, increase linkage to care treatment. So it's actually quite a public health impact. This index testing actually have a great public health impact, and therefore it's aimed at reducing HIV transmission, and therefore realizing epidemic control as a region, as a country. So this actually, I think the last slide, this actually showing assisted HIV partner notification of a young woman who engage in transactional sex. So this showing from one index how many actually of sexual partners turn out to be HIV positive. So you are able to see the purple one is the HIV positive, the green is the negative, and the other one is not tested. So out of the one index clan, we are able to see actually the web. Out of the one index clan, we managed this through this kind of demonstration, which was done by LFCT Kenya. We have 4 HIV positive sex partners shown there. We also have 4 additional HIV positive adults, and we have 1 HIV positive adult and child. So out of one index clan, there are 9 positive individuals identified. So you are able to see the network contact tested up, which actually tested positive. So you're able to see that 1 HIV positive social network contact, 2 HIV positive sex partners, and 1 additional HIV positive adult, and 1 HIV positive child. So it's actually all HIV positive individuals are enrolled into care. This is actually data and demonstration project, which was done by LFCT Kenya. And we appreciate LFCT for actually helping out in terms of APNS to show that it works and it can really help in terms of identification and also improving adherence to actually maybe optimum linkage to care and treatment, and also of course retention in treatment, and generally reduction in terms of transmission when it's actually done well. So I think that's all that I needed to present today. So thank you so much for listening to me. At this point in time, I want to hand over to my colleague, Dr. Jonathan Mwangi, to take us through the next session, which is ethical principle in APNS. Then once he has actually completed that, we'll actually have question and answer session. Thanks, and over to you, Jonathan.
Thank you. Thank you very much, Nora. Maybe you could pull down your slides. I'll load mine. Then we can continue from there.
Done.
Yeah. Thank you. So as you've heard, I'll be taking you through ethical principles. Then we shall look at sexual networks and social contacts and what that means within the context of APNS. And then we just go through, considerations for offering APNS. Really, this will be more of a revision session, considering most of you already offer, these services. So confirm you can see my screen. So I'll be going through this, and I'm glad I'm starting here, considering the last time I was offering sessions for this refresher training, I actually tackled the issue of ethics, and I'm glad this is where I'm picking up, again. So APNS, in terms of our guiding principles, they're very much aligned to our HTS, guidelines, and this should be under the 5 C's. And these 5 C's we all know include consent. The client should always give consent for testing. The service should always be confidential. And of course, we should also always offer counseling services, provide correct results, and more importantly, also endeavor to ensure we offer connection or linkage to prevention or care and treatment services. 2 things, to highlight. That coerced or mandatory testing is never appropriate, and I need to underline that. And I think I mentioned it in my last session that we discussed, ethics, that coerced or mandatory testing is never appropriate. This coercion, whether it's coming from the health provider, from a partner, from a family member, or even any other person, including persons in authority, this should never be. An individual should be able to freely offer themselves for testing and freely consent of their own will to receive, testing. And in that, you're saying the underpinning ethical principles for HTS is that we should always adhere to these 5 C's when offering HTS, and of course, APNS as well. Other considerations are that APNS is also client-centered, in that this should be focused really on the needs and the safety of the index client and his partner and her children. And I also like adding to this point, also the safety of the healthcare worker. I think our providers, many of you who are tuned in for this session, really, put in, a lot of effort. And even as we offer services to our clients, we should ensure that we are also safe. The client also should choose the best option for his or her circumstances. I think Nora has taken you through the various ways we can offer, partner notification services. And as such, we should be able to clearly explain all those options to the client, and the client should be able to make the decision of what's best for them from their circumstances. And of course, we should always say the services should always be delivered in a judgmental, manner. And the focus here is really to help the client make sure that we're able to reach out to their sexual partner on their network, make sure everyone is identified, people living with HIV are identified, and of course they're linked to to treatment or prevention services for those who are negative. And really this should be our focus as we offer services, and we should at all times ensure we're offering our services in a non-judgmental manner. Of course, confidentiality remains key. I don't need to overemphasize that. As counselors and healthcare providers, this is a paramount principle that we should always observe. A summary of just what I've said, that these services should be client-centered, should be confidential, should always be voluntary and non-coercive, should be free of charge, especially in our public, setup, and also faith-based facilities, should be non-judgmental, should be culturally and linguistically appropriate. I like that box very much. And for those of you who've interacted in the field, when discussing, partner notification services, we always discuss how are sexual relations described in the context where you're practicing. That is usually very, very important to ensure we are communicating clearly what the services entail to our clients, to make sure we are able to communicate clearly what maybe primary sexual contact, secondary sexual contacts would entail. It will be very, very important we have we use culturally and linguistically appropriate language within the given setting. The service should also be accessible to all, and of course, as always, should be comprehensive and integrative. Comprehensive in terms of we offer comprehensive services in terms of the entire continuum of services for HIV counseling services and linkage to treatment services, and of course integrated. They can be integrated with other services. As I finish on the principles for partner notification services, again to repeat about voluntary and non-coerciveness, accessibility, and of course the services being comprehensive and integrative to all who have access to these services. Let's again just do a quick revision of what sexual partners, networks, and social contacts within the context of partner notification service. What does this mean? Like I said, this is really a revision session, and I was really wishing I'd been a classroom session because we would really engage and would want to hear from you. But anyway, I'll just quickly go through this. Who is a sex partner? Sex partner, mainly we're talking of two or more partners involved in a sexual relationship. And in this sexual relationship, there may be individuals of the same sex or of the opposite sex. As not indicated earlier, majority of our HIV epidemic is largely within the heterosexual population, meaning these are sexual relations between people of opposite sex, that's between male and female. But we also remain cognizant that we might have sexual relations between persons of the same sex. These are our key populations where we have men who have sex with men, as well as females who also have sex with females. Sexual partners may also be involved romantically or are just casual sex partners without any plans to get involved in a long-term romantic or intimate relationship. Again, I would have loved just to expound on this point in terms of what this means, and perhaps get reactions from you, what this means in different contextual areas, both by region and by culture. But as we shall see in the next slide, we have what we call casual relationships, and these are individuals who are involved in an ongoing intermittent sexual relationship for whatever reasons, which includes transactional sex. I will explain a bit more what we mean by transactional sex, and I'm sure all of you are well versed with this. Of course, this is where people have engaged in sexual, relationships for gain, for favors, be it money, be it gifts, or be it other favors that people engage sex in exchange for. Perhaps classically, what in our environment might be called, the sponsor relationships. I had in some settings called sponsor. In some other settings, it's called being a blesser. I don't know what your context is, but really that describes what we would call transactional sex, where you have these sexual relationships where sexual, is sex in exchange for favors, gifts, or other considerations. The other dynamics that could be involved within these sexual relationships, one, if there's HIV infections, the partners may not be responsible for each other. Here we are making reference to the casual relationships. Partners may also subject each other to stigma and discrimination. Violence might be pervasive, and contact tracing for partners may be hard or difficult or take longer. Remember, we're saying these are intermittent, relationships. Maybe you have a partner in this town, in another town, and you engage with that partner as and when you are in those geographic, locations, and these are casual relationships. And that's what we're saying. Contact tracing for such might be difficult. And as I had mentioned earlier, safety of the provider should be paramount, especially how some of the partners in these casual relationships are approached. The provider must prepare for eventualities, but of course, by engaging with the primary contact, we should be able to tease out what are some of these, eventualities or concerns that may arise. We have those in steady relationships, and these are individuals who are involved in a relationship that is well defined and may or may not be exclusive. But the key thing here is the relationship is well defined. The partners in these relationships are, however, more committed to each other. They have a romantic or intimate feelings towards each other. They may be married, planning to be married, living together, cohabiting, dating one another, may have children. And what to note because of this connection is, elements or aspects of jealous might be, are quite significant, because these are people who are committed to each other and they have intimate, feelings towards, each other. The dynamics for this relationship, contrasting to the casual relationships, is if we have HIV infection is present, there's higher likelihood that the partners may provide support to each other. Contact tracing is easier and might take a shorter time. And of course, counselor-supported disclosure may be easier than the casual relationships that we've mentioned earlier, and it may be easier to offer, couple counseling for these types of relationships. And the main reason why we are tackling this is, as we offer our counseling services in the pre-test counseling, it is important we're able to find out what type of relationships our clients might be having. For the individual, in terms of what are the benefits of APNS, I think Nora had already touched on them, but I'll quickly go through them. Is of course access to ART. We know early initiation to ART, of course, leads to better outcomes. It improves adherence and retention to treatment. To the individual also, there's increased access to prevention options, including, counseling, condoms, and VMMC. And here, we are looking at benefits for those individuals who might turn positive or negative. And these are now some of the sexual contacts to the index client. It might enhance self-worth. This is for client empowerment. If we walk the journey with the client very well and they're able to disclose to their partner, they feel empowered to do this. It may enhance, and there's enhanced support for those not ready to notify partners, where we readily should be able to offer the service and offer, joint, disclosure. And the individual is not burdened with the need to disclose results or persuade the partner to be tested, since, like I had mentioned earlier, in a couple, testing environment, you might be able to disclose, these results, or working with the client, be able to disclose the results to their partner. Further benefits to the population, of course, is reduced HIV transmission, which is the primary goal of HTS services, and of course to increase the number of persons on ART through the linkage services that we offer. Just a bit more details on who are family members, who are social contacts within the context of partner notification services. For family members, this essentially refers to individuals that are immediately related to the client in the following way. There could be children, blood children of the female index client. There could be children of a deceased mother whose death was HIV related or may have had an ascertained HIV status. There could be children of a male index client whose partner is either a known person living with HIV or the HIV status was also unknown. So these are family members that would be of interest when you're offering partner notification services. For the social contacts, and this is very, very, very important. And as you will learn, perhaps as we offer our services, especially those who are offering services to our key populations, we have what we call social network testing as opposed to partner notification services. We have social network testing. And here we focus on the social contacts of our index clients. And who are these social contacts? And this could constitute individuals who are not related either sexual or by family to the index client, but may need targeted partner notification services. Some of them could be siblings of the index client, where due course has been demonstrated beyond reasonable doubt that there is need for HIV testing. There could be people who are sharing sexual partners, where you have one, where within a network of individuals where they're shared sexual partners, therefore those would be sexual, social contacts within that network. Then you can have either people already known positive individuals, again, within such social networks. Then the other individuals within that network would be candidates for social network testing and would be referred to as social contacts. Also expanding to that is individuals who might be known to have high risk behaviors or risk to HIV or vulnerable to HIV. Individuals who might be sharing, drug injecting paraphernalia, be it needles, syringes, and such. And some of our key and priority populations that I've already mentioned in some of the groups that they may hang out within. This includes men who have sex with men, female sex workers, and persons who inject drugs. Either, like I'd said, in the hotspots they share or in the clients that they share. Some of the considerations for offering partner notification services, and like I said, some of these things will not be new. These are things we already know. But as I go through the slides, it's important that we reflect what do we do in our practice, what do we do in our hospitals, so that we achieve the objective of this refresher course to make sure we are all offering the same level and quality of services. So when should PNS services be offered? PNS services are not a one-time event. I think that should be critical, but rather they should be continually offered. One, immediately after HIV diagnosis. Of course, we know they form continuum of services in HIV diagnosis as we'll see in the testing algorithm, at least annually as part of HIV treatment services. And the reason why you might say at least annually as part of HIV testing services is, of course, individuals might have had a change in sexual partners, might have had a change in sexual networks or social contacts. And it's always good to interrogate to see whether there's new risk or whether there's change in the risk profile for the individual, and where appropriate, we should be able to offer partner notification services. And like I'd already mentioned, after change in relationship status. Of course, we'd only know this if you're continuously engaging with the clients and continuously finding out what's happening to the client during their clinical visits. And who should offer APNS? This should be offered by all healthcare providers, number one and paramount, with NASCOP HTS training. And this includes HTS, PMTCT providers, nurses, clinicians, linkage coordinators, or even case managers. But the basic qualification is the HTS, NASCOP HTS training. anyone who's received that, because we know within the NASCOP HTS curriculum, already it's integrated to include APNS services. And additionally to that, you might receive continuous training on APNS, you might receive continuous mentorship or CMEs on APNS, and that empowers and builds your skills towards offering these services. And where should the services be offered? Of course, we know at the facility, we have various service delivery points. It could be co-located in the VCT. It could be within the ANC setup, the TB clinic, the STI clinic, if you have. It could be also at the facility-based treatment sites. This could be a PMCT treatment site within the ART clinic as well. And of course, we know as part of community-based HIV testing programs, we know we have a small element of HIV testing services that are offered in the community. And even within that setup, APNS services are feasible and could be offered within that setup. What are some of the other considerations for offering APNS? One, to improve access, partners and children of index clients should be offered the option of coming to the health facilities for a test, or having a counselor or healthcare worker to test the partners within the community. And that this speaks to the point that Salah made earlier in terms of how do we offer the services and what's the context within which we offer the services. And we encourage during home testing to offer testing to all the household members you might find there. Of course, part of this, of course, is also to reduce stigma and, of course, maintain confidentiality of the clients that we had hoped to reach. I think I've already mentioned that first bullet. We also need to inform households that's why we've come to offer the services within that household or within that community. That's to ensure that we test all who might be eligible within the household and within that community as we offer community services. In high prevalence areas, HIV negative pregnant and breastfeeding women should also be offered part identification services due to high risk of mother to child HIV transmission associated with incident HIV infection. Some additional considerations. Appropriate security and confidentiality procedures. Like I've said, one, we should ensure the client is safe, their contacts are safe, and even more important, the healthcare provider is safe. We should not put ourselves at risk as healthcare providers, but we should always ensure that we are safe as we offer the services. And we always encourage to where feasible to ensure at least we are accompanied by a colleague as we go to offer these services within the community. Linkages are very important. The primary goal of case identification eventually is to link individuals to treatment. And even as we offer the services, even as we follow up the partners, we should have a robust plan to ensure that they're linked to health facilities to access ART. That we shall achieve to our overall objective for APNS of both case identification and linkage to treatment. And those who test negative, of course, there's always the provision for reaching prevention services. This includes condoms, VMMC, PrEP, and other prevention services. Of course, there's always the issue of constantly evaluating our performance and seeing what we need to improve, high elicitation skills, and I think this forms the basis of us continuously improving our services and us continuously improving our skills and us continuously achieving our goals of identifying people living with HIV and linking them to treatment. Allow me just a few more slides just to look at how the process is integrated within the HTS protocol. And like I said, this is not new to all of us. I think we know all this, but I'll just quickly go through especially the chart on the left side, where this takes us through the various steps. And on the right-hand side, we have what we need to consider as we take each of those steps. For step one, of course, is to introduce PNS to the index client and obtain consent. And we introduced these services way early during the the pretest, counseling, service, and even when the client now is eligible for services, it's imperative that we obtain, the consent, and that consent, preferably if we can have it, written, would be most appropriate. We need to document the same. Then, of course, we need to obtain the list of sex and needle sharing partners in the last 12 months, and we use the PNS register to record this. And after that, we screen for intimate partner violence. Remember, as I've said, we need to at all times ensure we are doing no harm, both to the client, to the contacts, and of course to the providers as well. And one of the things to do is, of course, to screen for risk for intimate partner, violence. And I think there are tools provided for that, maybe specific trainings, for around intimate partner, violence. And of course, we should register for that. And of importance here is we should exclude partners who pose high risk of intimate partner, violence, and you should refer the index client to intimate partner violence services where available. Should we find there's a risk or this client has been exposed to intimate partner violence services. And let me also add, for intimate partner violence, even when you screen negative for intimate partner violence, it's always good to follow up subsequently after the client has been engaged on treatment, whether there's been any intimate partner violence. And as I've said, should we find there's been risk or there's been an event, then we refer appropriately for the service. Step 4, again, is to determine the preferred method. And I think Nora had already gone through this, so I'll not go through that again. But more importantly is that we are all familiar with this. The key thing to underscore here is that the client should be offered all these options and out of their own volition, guided to make the best option for partner notification services before we proceed. And after that, after they choose which method would be they would prefer, we go ahead and contact them, and after successfully contacting them, we record their outcomes. And of course, we also provide other appropriate prevention services after we manage to test them. And these appropriate services could be linkage to treatment, or if they turn out to be discordant couples, other prevention services or other services for discordant couples. So really, that's in a quick summary, the key steps for partner notification services. Key things to remember: 1, to obtain consent; 2, screen for intimate partner violence, both when you're offering the services and also subsequently, even after offering the service. It's always good to follow up. 3, ensuring that we offer the client all the methods available, whether it's client referral, contract referral, or provider referral, and guiding the partner to choose what's most appropriate. And of course, subsequently offering the service and offering appropriate services post-test to both our primary client and their contacts. And some of these post-test services will include linkage to treatment and of course prevention services. Children of index clients, I know this is an area we've been focusing on. I think it's an area we'll continue to look at, and it's an area again we'll be really focusing going forward. And I know without treatment, we know children have a high risk for mortality, but with ART initiation, they are very good survival rate. Therefore, it's important we really also focus on the children as we're offering partner notification services. And the children to prioritize are all are children of all HIV positive women who are younger than 14 years of age with a non-HIV status. If your index client is a male, if they report that they have children and their biological mother is known to be HIV positive, deceased, or a non-HIV status, then those are children you need to prioritize for HIV testing. And as we've said, this should not be a one-off event, but even as clients are engaged in treatment, we should screen them routinely to find out if they have children that would be eligible for testing, because again, we do not want to miss out on children. And as we noted in our 1990 cascade, we are still missing out a significant proportion of children to be put on, to be identified and put on ART. So therefore, children remain also a focus for us, even as we offer pan-education services to sexual and social contacts of index clients. As I almost come to a close, documentation, again, this is just a quick reminder that the PNS register is used to document both the names of the children and of course the index client and their contact. And of course, as we offer the testing, we should also record the outcomes for the same. And whether you offer the testing in the facility or within the community, it's always good to indicate whether it was community PNS or it was facility-based PNS. I think that's the last slide, and allow me to stop there. And I wish to turn it back to Collins and Mary to take us through the Q&A session. Thank you very much for listening. Asanteni.
Hello. Good afternoon, everyone. Good afternoon, everyone. You can hear me?
Yes, we can hear you.
So there are a number of questions which were raised. There were some from the Q&A, and there are some which were raised on the chat. So I've managed, we'll start with this first section for the Q&A. Okay, this one might, well, the presenter was too fast, slow down the pace. I think for the pace, I think it was good. So, because we have the live YouTube recording, so the recording will not disappear. So even after this session, you can be able to go back to the YouTube link and you'll be able to receive the material. So you should not worry about basically if you missed out something, whether you're not concentrating fully. So the material will still be there on the YouTube live page for the NASCOP Echo. So you can basically get to review it even after the session ends. Then how long is the right backtracking time for contact for PNS? Should be implemented knowing the underlying intervention. That's from Raphael. So should I read all of them, or we address them one by one?
You can read all of them, then we can quickly tackle them.
Yes.
Okay, then. The videos should be loaded on a chronological order to be able to watch with good flow on the YouTube from the first to today. Okay, I think that one is on my side. I need to follow up in terms of basically arranging all the webinars which you have conducted so that they can be reviewing basically in terms of the weekly sessions which you have been conducting. So that one I'll work on it from my side. And there's someone asking about the points. I am not able to answer about the points now, but that one I'll basically make a follow-up and then I'll get back in terms of the CPD points. Then, can we get the slides for this presentation? I think we already have the live link, so I don't think we need to share the slides. Basing on the number of people who are joining for this session, there are around, because according to the number of people who registered, we had 1,870 people who registered. So sending emails to everyone would take a long period of time. So I would advise that you just search the Hts Refresher Webinars and you'll be able to get all the material that you need that was presented today and also the previous training sessions. Voice is not clear. Notes. As Kenyans, are we at the prevalence rate? Is it at 5.7%? And the world, which is Kenya according to the prevalence rate? I'm not able to get the question well. Oh, he's asking about the prevalence rate of Kenya. Is it at 5%, 5.7%? Are we doing written consent with the index clients? That's another question. Difference between passive referral and mutual referral in APNS. Why 1 year down the line why 1 year down the line in listing sexual partners and drug users too? I'm not getting the question well, but I hope you have already received the question. Then Rosemary Muyoti, social worker from IRDO. Why is it that APNS guidelines are focusing on sexual partners within 12 months? What about other previous sexual partners? When the index client is not willing to list sexual partners, which skills can you apply? A case whereby an index client has refused for line listing his or her sexual or injecting drug partner, how can we go about this? From Irene Achuth, Huduma Center, Mombasa. I think those were the questions from the Q&A. I think we can address those ones before we go to the ones from the attendees who have raised their hands. Back to you, Jonathan. Hello.
Yeah, Jonathan, are you still on? So probably I can chip on 1 or 2 questions. Let's wait for Jonathan to chip in.
Okay.
So there is the last one, which was asking plans reviews to line list the sexual partners. This is actually some of the hiccups that is experienced through partner notification services. So, and you know, over time, we've had our Hts providers done capacity building. So at least they're able to really know how to do these skilled kind of interventions. So at least they're able to even have exchange programs among themselves so that we have, of course, we have those actually who are quite good in terms of talking or eliciting the contacts of the clients. So if you find, for example, index class is not ready at that point to really elicit the sexual partners, of course, with a lot of skills that you have as a provider, you give time and you keep on talking with that particular person. You cannot coerce, it's actually a voluntary process. So you allow the person to really contextualize what has happened, and then keep with time, they will be able to open up. So it's a matter of using skills that you have gained over time as ATA providers, and knowing that this is a voluntary process, to allow this person to actually take through the process and understand, and finally maybe accept to keep the sexual partners. So it's a voluntary process, and you just use the skill as ATS providers, so at least you know how to really go about when you have such particular kind of barriers. So you really need to know how to address barriers by asking yourself, were you actually in a good position in terms of talking and establishing a rapport with this particular kind of client before even asking about the sexual partners, listing sexual partners. It starts all the way from counseling. So you need to give all the package, start from counseling, counseling when they turn positive, all the way. It's a whole cascade of all that kind of information that you give at the right time. So when they are not ready, you give them time, and over time they will be able to actually open up with time to actually give the list of sexual partners. I was also asking about why PNS is focusing on sexual partners. Remember, when the first presentation, we actually discussed in certain slides, why are we focusing on sexual partners? So we realized, based on the various studies that have been done, we have most of the incidence of HIV is actually through heterosexual activities. So we have sexual transmission of HIV. So most 70% in sub-Saharan Africa of all the incidence of HIV is actually through heterosexual. That's why you're focusing on sexual partners. And of course, it also gives room for those who are actually at risk. They're actually having activity with this, a client who's actually HIV positive, and they're not aware. So it gives a better opportunity for those partners of the index clan to really know the HIV status. If they are positive, of course, we optimize as early as possible linkage to care and treatment. We prepare the care so that when they start on treatment, they can be able to adhere to treatment and also remain on treatment. So those are actually HIV negative in this case can be referred to all the prevention interventions, which include like if they are males, PMMC program. If they are, we also have the PMTCT intervention. We also have a PrEP. We also have PEP. Also have condoms, name them, so that at least they remain negative. That's why you are really focusing. The reason why you are focusing on social partners is as a country, as a region, globally, we are trying as much as possible to really optimize case identification so that at least we actually realize epidemic control. So why we are focusing is so that at least we really roll out those intervention strategies which have proven to work based on various trials which have been done globally. And this actually show that they are quite high yielding, so that at least we just don't test volumes and volumes of people who are not actually at risk. So that's why we really have to optimize the screening in the facility, in the community, so that at least we're able to really do targeted testing. That's why we are really focusing on social partner as one of the strategies which has proved to be working based on the various studies. Somebody was also asking, I saw a question which was asking about how urine can be used. Maybe Jonathan can talk about this. Somebody was asking about how urine can be used to test HIV, and also we talk about specificity. So you can have maybe Jonathan addressing on that. Of course, we also have consent, which are from NASCOP, the written consent for when offering Hts services. So there is a form which has been developed by NASCOP, which is being used by Hts providers to actually have index clan consent in terms of participation in partner notification services. So there's a form that has been developed and actually being used by providers across the country when it comes to index testing services. So I don't know whether Jonathan is on board to address the remaining question. Jonathan? So I'm not getting Jonathan. I don't know whether Samson is still on board, but I think I've addressed most of the questions. The line listing and tracking. Somebody was asking why we need to really track. I think the question meant the reason why we are tracking for a period of 1 year. So this has been informed by various studies. That's why it was arrived that it actually gives optimum results when you can give time and do a follow-up for a period of 1 year, because some clans are not ready depending on the circumstances, but with time they'll be able to open up. So of course, and you also look and follow up the contacts, the web or the contacts. So in this case, the reason why 1 year was given is because of the trials which was actually done across the world, and to prove that it is actually quite, in order to have a period of about 1 year, that at least you're able to track this particular clan. So this was informed, I think, by various studies that has been done globally. So I don't know whether Jonathan is on board. If there are any other questions, the team can still raise. Back to you, Collins. If there are other questions, the team can raise up.
Okay, I think I would like at least to move to at least the attendees, so that at least I involve them in terms of the question and answer session. So I will start with the first one. So please be very fast when I call your name. Some of you have not written your actual names. They have different names, either mobile phone names. So if I call out your name and you have raised your hand, please be quick to respond. So we'll start with Benta Otieno. Just 1 minute. So Benta Otieno, you can now proceed to talk. So we'll move to the next one, which is G7. Don't know who's G7. G7 think, you can now talk. Evelyn. Evelyn, you can now talk. Ernest, Kirui. Gladys.
Hi, Nora, Bradwell, Collins. I don't know if all the questions have been looked at as of now. Just
Yeah, hi, Samson.
hi, Nora.
Not all the questions have been addressed. We are trying to move in at least to involve the attendees so that we can see whether they have any questions that they would like to voice out.
That's fine, thank you. Just to acknowledge, you have Julius, one of our colleagues also on the line. Julius could also help with the responding to questions. Thank you.
Okay.
Hi, Julius, you're welcome.
Thanks, Nora. Thanks, Samson.
So
I think there was a question. I think Julius can answer for Samson. So I don't know. They were asking about how urine can be used to test HIV and its specificity. Maybe Samson or maybe Dr. Oliech can answer that, if urine can be used for testing HIV. And then also, I think I've seen some question written about prevalence of HIV in Kenya. If somebody wanted to know. Yeah.
For myself, I'm not sure about urine testing for HIV. I think now for our current guidance, I think we only use blood samples for testing for HIV. Probably in a research setting, this could be possible, but we can be able to just to find out and then probably share with the team. I think as we're sharing the slides, we can get more information, probably in a research setting, how it's being done. I know for TB, there's current research in terms of testing for TB using urine, especially for the children, who it's very difficult to get blood samples, to get sputum samples. But for HIV testing, I'm still not sure, but we can be able to check on that and refer to the team. Unless, Samson, you may be able to have information further on that.
No, actually, Doc, I totally agree with your response. And probably in this forum, I would really like to encourage the participants to stick to the national guidance and stick to the national testing protocol and look at the bigger picture as we move forward to as we move towards epidemic control. So we are looking at a public health approach. I know, like indicated by Doc, in a research setting, probably some of those have been indicated, but again, more literature needs to be looked at to support that. But in our national guidance, I think the protocol is clear, and we would like to reiterate that we need to continue to align and stick to the national guidance.
I've seen the response from Rafael Langat, who is the DOD lead for the lab, is saying that urine has not been approved in Kenya, but only the blood and saliva can be used for HIV testing. Thanks, and back to
exactly. Exactly.
So probably you can mention about the prevalence, Samson, HIV prevalence. Somebody wanted to know what this can.
Maybe I can pass to Julius as I take a question on another meeting. Sorry for that.
Julius? What I know, the prevalence of HIV in Kenya is below 5%, not 5.7. So probably I could check on the figure and paste as a response as we wait for the other questions from the team. Back, please.
Okay, so we can continue. There are some other questions which were raised. So I can continue with some of the questions which from where I stopped from. So this one was directed to Dr. Jonathan. Thank you for your elaborate presentation on PNS. In the most recent guideline on index testing, an additional section was added on monitoring and reporting of adverse events. At when should providers screen index clients for adverse events? Should it be for all index clients who gave consent to participate in the index testing, or a percentage of the clients? Then we have another question: in the scenario where sexual contact is a police officer and threatening you, what should you do about it? That's from Ruth. Then, good afternoon. This one, Ernest. It has been a great presentation. I would like to acquire the slides. How may I go about it in an acquisition? Okay, I think I had shared the information on how you can, even if we don't share the slides, on how you can access the information, because currently the information is online on the live YouTube link, which will not even disappear after the session. It will still be there. So you can also review the materials online for this session. Then clarify on the age a child should be given consent for testing. In the scenario where sexual contact is a police officer and threatening you to use GPRS to find you, because you have contacted the HIV test, you have contracted the HIV test, contacted for HIV test, how would you go about it? How do you deal with a police officer, whether violent or not? Well, this is another question about the police officer. Okay, then I think I'll read the last one before we can respond at least to the ones which I've gone through. Do we have a register for PEC, which is current and updated for healthcare workers? That's from Grace. I think we can take those ones for the time being before I move to the next session.
Thank you so much, Collins, for putting together the question. I'm not sure whether my colleague is still on, Dr. Mwangi. It seems to have actually on for another meeting, but I could chip in and respond to some of the questions. Okay. So, hello?
Hello, we can hear you.
Okay, there was a question which was been raised on adverse event screening, and somebody said this is additional portion which has been added to the PNS section. So, and somebody wanted to know when we need to actually monitor adverse event and when we need to screen for adverse event. So, I will not be able to maybe discuss exhaustively in this forum. This actually, the discussion is led by government through NASCOP. So it is progress. And what I know is that NASCOP is reaching out to all the stakeholders to look at all these portions, or including the monitoring of adverse event, including maybe IBC, including all the tools on the same, and should be able to, I think there's plan to actually have the stakeholders to really chip in after they have actually shared all the information, at least as government, they'll be able to give a way forward. So we are still waiting for the next step by the government, because this is actually under leadership of NASCOP. So I don't want to unpack on that, because we have NASCOP leading the process. So somebody asked about sexual conduct about the police. I've realized there are so many questions about the police, about other people. So I want to try and probably maybe respond, and then I will have my colleague, Dr. Oluwech, also trying to chip in. I know this can be more so when it comes to the key population programming, where sometimes they have challenges in terms of maybe encountering a police when they are actually offering the services. Also, like in this case, scenario. So somebody wanted to really know how to go about. You know, I may not have an adequate answer on how to go about such a difficult moment. So as an expert in HIV testing services, in also PNS, there's a way we really have to
Laura, we have lost you.
Sorry, are you getting me now?
Now we are getting you.
Yeah, sorry. So I was talking, I don't know what you got about adverse event. I could repeat on that.
Just repeat.
No, sorry. So somebody was asking about some components which has been added on assisted partner notification protocol or a guideline, which mainly look at the adverse events, and they really need to screen and also monitor the adverse event. So I said I'll not be able to actually discuss at this point because this is actually under leadership of NASCOP. So the NASCOP actually through the government through NASCOP. So it's actually under the government. They're actually working on checking and reaching out to all the stakeholders to discuss on this particular component of PNS. So I know probably NASCOP will be having a stakeholders meeting. So at least all the concerned, all the stakeholders in this country will chip in terms of various components that has been added on PNS, so that at least we'll be able to have a safe and ethical index testing in this country. So I don't have a mandate to talk about that because we have the government leading the process and we'll get a way forward as led by the government. The process is continuing and the government will give us a way forward as a country through NASCOP, which is actually leading the process. And then the second question which was raised was about sexual contacts, and somebody was really concerned about where we have a police in this case. And of course, maybe the police officer could be threatening and can be a bit more scary on how to roll out the PNS. So as I was saying, I may not have a solid answer on how you go about it because it is this a highly skilled intervention that requires a skill, and the skill varies depending on what's happening in that particular moment and the person you are dealing with. So because of that, you try as much as possible to see how you can address this particular person, and of course establish a rapport so that at least you actually, if it is so much harsh, you give time, and actually with time establish a rapport and see how best to go about it. And of course, work closely with other providers in terms of getting the skills to really give this information to this particular person. At least you cannot actually get harm because people can receive information differently and some can be harmful. That's why as a provider, you have to be very technical and see how best to overcome this kind of scenario, and even if possible, contact some of the other more skilled providers to help you on how to go some of these issues. So I may not have exact, but it depends on what happened in that particular scenario. How do you go about it? It varies across. There is no solid answer, but you have to be careful. Try your best based on the skill that you have gained. Consult your colleagues and even other experts and see how to handle such a particular case. So I may also go to another question. I don't know if my colleagues are in. They can also chip in. Somebody was asking about the age for consenting. I think initially it was 18, but I think now it's 15 years, as indicated in the Hts guideline 2015, which all of us are aware that it is under going review. We have Hts policy or Hts guideline being reviewed at the moment, led by NASCOP. So I know a number of things could be amended based on what is, what inform the policy change is data outside there. What is actually, things keep changing based on time. So remember, life is dynamic, and also the epidemic also is dynamic. So based on epidemic control measures that we have in place, and also the trend in terms of infection in the country. So there is way we need to actually look at best way of improving case identification. That's why we have other components being added in the guideline. So it is good that the guideline is actually under review, and still stakeholders also will be involved. We also have technical team working on it, and we'll have a revised guideline. The NASCOP team, that's the MOH leading the process, and I think we'll have a reviewed guideline once it is ready, and we'll have all those components that have been raised probably being addressed before the final reviewed copy is printed for circulation. So I don't know whether my colleagues are still there. Somebody asked about PEP register, if we have the PEP register. So I know we are here to discuss about the PrEP and REST. So probably we could actually, we can have somebody chipping in, but we can have that because we'll have tomorrow going forward, you will have the component of prep. We also have component of prep, which will come from next week. The next session will likely have those are the components of ATS package being covered in the next training. So you'll be able to have all these questions asked once we have those sessions presented by the next presenters in the subsequent trainings. Thanks, and over to you, Collins. And if there are other questions, and my colleagues can also chip in if there's anything forgotten to address.
Okay. So I would like to now, at least I see there's one hand from the audience, which, Beatrice, if you can be able to unmute yourself, please, you can unmute yourself. Beatrice, we can hear you. Beatrice, do you have a question? Beatrice Geoffrey.
Hello.
Hello, you can ask your question. No, we can't hear you.
I don't have a question.
Okay, can lower your hand. So, Linda, you can ask your question. Linda, do you have a question? Eunice, do you have a question? Okay, come out. You can ask your question.
I've seen a question, Collins. Somebody's asking if a discordant partner in sexual relationship can remain negative forever if not using any precaution, like if not using PrEP, not using condoms. Somebody, Judith Kwamboka, is asking a question: if a discordant partner in sexual relationship can remain negative forever if not using any precaution. So I think this is, remember, if not using any precaution, of course, there is high likelihood that the negative partner will actually turn out to be positive. So there are so many parameters, there are so many contributory factors to the change in the status of HIV. The person or the partner who is HIV positive actually should be on treatment, and adherence should actually remain 100%. And therefore, the one who is negative, they likely need to use precaution, like of course use of condoms, so that at least the partner in question is not infected with HIV. But if there is no precaution, and of course probably the one who is HIV positive is not adhering 100%. No, adherence is a component of so many factors, including adherence to, of course, to clinic appointments, adherence to timing of taking the drugs, adherence to clinic appointment, and also adherence to maybe picking the drugs from the pharmacy, which is also affecting by so many factors like the care system, and also have factors including like the household factors, and also the individual in question. So in this case, if the client who is positive is not 100% adherence because of so many factors that can affect adherence level to treatment, of course, and if the partner who is actually negative is not using, there's no precaution like use of condoms, definitely the one who is negative will turn out to be positive, especially if adherence level is suboptimal for the one who is taking the ARVs. That's why it's like a probability. You all know what you learn in math sometimes, but we have a probability where you have some balls, white and red. So when you mix them on a container and you ask what's the probability of picking maybe a red ball, for example, there is high chance. So of course the same thing. If they don't use any precaution, they will turn out to be HIV positive. That's why we have to really package the information well when they come to the clinic, so that at least we actually avoid as much as possible transmission. One who is actually HIV negative. And of course, give more information to the negative, like linking them for other prevention interventions, so that at least they actually remain negative. Thanks, and over to you, Collins.
So I think now there are some people who have raised their hand. I'll start with Kamau, because I've seen your question is also on the chat. I think you can raise it up, or you can voice it out. So Kamau, you can meet and speak.
Good afternoon. Yes, my question is,
at what point can a service provider or a HTS provider break the rule of confidentiality in APNS?
Okay, thank you for your question. So we'll take another one first before we respond to that one. So from Eunice. Eunice, you can unmute Atego. I think we can respond to that one before we go to the rest. I think they're having challenges with unmuting themselves.
Thank you so much, Collins, once again for pulling the question from the chat. So I don't know whether my colleague is there. I don't know whether we have Anangwe on board. Anangwe, are you there?
Dr. Talam, I'm also on.
Okay, please. Okay, please. You want to respond to that?
Yes, so the question on confidentiality. Confidentiality is not broken in APNS. We do not even have an exception where you break confidentiality. You must observe all confidentiality. I think you may be asking this in regards to testing in general. Testing in general, confidentiality can only be broken in terms of where you have like testing that is commanded through a court order. That is the only time you can break the confidentiality. But in terms of APNS, there is no time that you break the confidentiality of APNS. And I like the way Dr. Talam has answered the questions, where there was a risk and a policeman and everything. Remember, in the principle of do no harm, we do not advocate for the client being in danger or even the provider being in danger. So it's not a must that you must get all your, the partners of all your clients. If you perceive any risk, do not proceed. Just leave it alone. In case there are any issues, we always work under the umbrella of the lab technologist who is doing the testing. You have a DMOH, you have your superiors report, and the right procedure will be taken. Thank you, and back to you, Dr. Talam.
Thank you so much, Mary. It's great that you are here to also support the Q&A. And again, thank you for your leadership. So if there are other questions, maybe Collins can help us to poll.
Okay. So I think Eunice, you can ask your question now. Maybe allow Sacred Heart. Sacred Heart, I don't. So,
hello.
Okay, can I ask your question?
Okay, my question is about the discordant couples. You said that it is unless the negative partner is enrolled for medication, there is a probability of being infected. But my question is, because there was a theory whereby we are told that, I don't know if it is proven, that in a discordant relationship, the negative partner has no receptors. So what will happen, because the theory said that there are no receptors, that's why they don't get the infection. So what will change if they continue like that? Thank you.
Okay, Dr. Talam, you want to take that or I answer?
Please go ahead, Mary.
Okay, so that's a very good question in terms of discordance, where we have one partner who's HIV positive and another one who is negative. The theory on the receptors is not totally proven, because at any one point in time, as long as the couple are still having unprotected sex, the negative partner will turn positive. So that risk is always there, and it's always a potential risk for them turning positive. And that's why we must insist during counseling on continuous use of protection, that is use of condoms. And remember, this negative partner also is a candidate for PrEP who needs to be on pre-exposure prophylaxis. Next week, we will talk about that. So that theory, nothing is really totally proven. Some studies have shown some not having receptors, but remember, over time, the negative partner will turn positive. We just can't tell when. Many characteristics, I mean, there are things that determine positivity of a person. Of course, the viral load of the positive partner, how high it is, what kind of sex are they having? Is it oral sex? Is it anal sex? And the risks differ. How many times do they have sex? The more, the higher the risk. The diet, and many other things, and the CD4 count of that of the positive partner. So there are many things that determine that, and that's why we insist on them using protection. That is regular and correct and consistent condom use for the discordant partner. Discordant couples are people who need to be kept being seen together within the CCC. Even as the positive partner takes their ARVs, the negative partner needs to be on PrEP. Anytime we have any perception of risk, this is a candidate for pre-exposure prophylaxis. Thank you. I hope I've been able to answer.
Thank you, Mary. This is Anangwe, and I can probably just put a follow on your comment to help respond to a question in the chat from Thomas Ogwethe. Thomas is asking whether those who have oral sex can as well be screened for APNS, or it's just those who are having vaginal and insertive, sex. So I mean, the guideline is clear that you know, when you're looking to implement index testing or assistant partner notification services, you're looking at a network, and this network is defined by either a needle sharing network or a sex network. So it does not unpack. As Mary says, there are different thresholds to the risk of transmission based on this, or if you want to unpack the kind of sex they're engaged in. But I mean, risky behavior is risky behavior. We are programming in a public health space where we follow general guidance, and we try as much as possible to cast the net wider to capture those with the risky sexual behavior, and then offer them this service to, you know, cut the chain or interrupt the chain of transmission as already provided and presented by my colleague Nora. So I think that should be able to answer that question. Another question from Agnes Naliaka to panelists: Can we have partners of same gender as PNS? Under which circumstances? I mean, sex partners are sex partners, whether they are same gender or they are not same gender. And again, as indicated by Mary, the threshold of transmission may vary, but again, they are exposed, and therefore there is need to implement assisted partner notification in that subpopulation. So it's important. And sorry for my connectivity in Tambo, Samuel. I've noted your comment on. I hope you're able to hear my responses. Thank you, and over to the chair.
Okay. So there are some questions which have been raised here. I think I can allow, because they have also raised their hands. I'll start with Grace. Grace, you can speak. You can ask your question, because I've seen you've also raised it on the chat. Grace Mukwana. Grace, we're waiting for you. You can speak. Okay. I think I might have to move. In the essence of time, I need to move to the next one. Cornelius? So for what I can just do, I can just read out the Grace question. In identifying PNS, can you call the partner if client has shared his or her partner contacts? how do we inform the partner? Do we say you have do we say you are at risk of getting HIV? So that's from Grace Mukwana, Beacon of Hope. And then there's a question also from Peter. My question is, now that we can be using one register for both PNS and APNS, due to both being quite the same, I didn't get your question. My question is, can we be using one register for both PNS and APNS due to both being the same? That's from Peter. Then we have another question from Milka. Most of the index clients give us wrong contacts, mobile numbers. What can we do about this? I think we can take those three questions first for the time being.
Collins, I can probably start with the first two. I'm trying to multitask. I'm responding to questions in two different meetings. Wrong contacts. I think the strength of the relationship that is established with a client right from the pre-testing session is critical to the outcomes of that session. And the skill of the counselor, as was discussed right from the inception of the webinar last month, and through the sessions we've had, is important to the counselor being able to establish rapport and being able to get that accurate, detailed information. It is important to elicit to a client and ensure that you allay all the concerns that they have. And then early in the session, when you look into the testing protocol, be able to discuss some of these issues with the client in terms of confidentiality and shared confidentiality. Anecdotal information has shown that some clients give wrong information because they are concerned about confidentiality. And these are some of the skills that we want to impart within our providers to ensure that we're able to inculcate this messaging as part of routine counseling in the session. So it speaks to the counseling skills, but again, client factors can play, but it is important to be able to improve our counseling skills as providers early in the session. About PNS and APNS being one and the same, and whether we can use the same register for that. So first of all, I want to say that we know in our facilities we have a line list for APNS, and we are calling it a line list because it's not yet nationalized to an MOH tool, but we know that the Ministry of Health through NASCOP leadership has allowed programs to put this in place for the purpose of moving index testing as an intervention forward. Now, you will see in presentations, in trainings, and in discussions, an interchange in the use of partner notification services, assisted partner notification services, index testing as a modality. So this speaks more or less to the same PNS and APNS, and hence use of the same line list. Now, I know more and more will be discussed as we move forward. We continue to put a lot of emphasis on ensuring confidentiality of records as we implement index testing. So it is important to mention that as I finish my submission. Thank you, and over.
Okay, there are some interesting questions which I'm reading from the charts. So I'd like to at least start with the first one from Joanne. If the index client listed by sexual partner travel to a country, how can you do follow-up? How can you do the follow-up if the phone number is not going through? Then we have the second question, Eunice Olwero. I worked for the Uniformed Forces at Memorial Hospital. How best can I introduce myself during a phone call, considering confidentiality of the index clients when I have been given a sexual contact by the index client? Then from Hilda, a client came and as we were talking, he knows of a man who tested tested severally HIV negative, but his 3 wives died of HIV-related illness. How is that? Then we have another question also from the same person, we have from Eunice. Majority of the clients are not willing to give out any contacts. They just decline regardless of skills, of the skills that I employ. How can we handle such a situation? Then from Simon, is it okay to trace APNS clients who have GBV history? I think we can take those questions for now.
Colleagues, I didn't get the last question.
Is it okay to trace APNS clients who has GBV history?
Oh, great. So I think I'll start with that one, gender-based violence. Any client who has a risk of gender-based violence is not a candidate for partner notification services. And that's why we screen, and Dr. Nora went through the slide where you ask the questions of whether there is a risk of them having gender-based violence. So any client, and there is a risk, do not proceed with partner notification services. You need to refer that client for GBV services in the relevant ministry, the relevant facility where they will get GBV counseling. There was a question, the other one was regarding, this question regarding somebody who, according to the history, the other previous partners died of HIV. In this HIV sense, you always rely on the information that you're given by the client. It may not be necessarily true. Remember, you do not have the postmortem, you do not have the records where you have looked at the test of these people. So it is difficult to, and I'm seeing a lot of questions that are being asked in regards to that, because the HTS provider is a confidant to, and they keep a lot of information which you know, and of course you are sworn by confidentiality, which you can't reveal. So you may feel like maybe you're living in a place and you know the people around, and of course there are stories about who's positive and all that. You cannot divulge any information at no time whatsoever. So the issue of whether this one died of HIV, this one died of HIV, it is what the client tells you. Remember, you cannot confirm that by use of the tests and review. So that's something I'd be shy to do because I do not have evidence and follow. Regarding disclosure, it is important to give clients time to disclose. Some of the acts that we had in the HAPCA Act, Chapter 24, which was allowing disclosure, was taken away by the courts. It is null and void, and so disclosure needs to be taken up very carefully. Unless for a fact that you know that person is infecting others, you cannot disclose. So disclosure is something I'd like you to just give the client time so that it's them disclosing. In regards to what Dr. Nangwe has answered, regarding the APNS, PNS, I won't repeat. Yes, he has answered it. Remember, it is called assisted because we have always had partner notification services, but it has never been active because we left the clients to be the ones to do the notification, and it never happened. So, if the healthcare provider comes in to assist the client to do it. Back to you, Collins. I can't remember. There's another question also that I have seen here. On carrier receptors, I think that one we have answered. There's a comment. Okay, back to you, Collins.
There's the one for traveling up country. If the index client listed by the sexual partner traveled to up country, how do you do follow-up?
We can use the, yes. If the phone number doesn't go through, then there is no way of carrying out that follow-up. Unfortunately, from one county to another, right? Yes. Yeah, because if you don't have the number, where else are you going to get that client?
Okay, there's another question here from Galaxy S8. In some cases, perpetrators of rape and defilement are escorted by policemen for testing. While cases has not gone to the court means with no court order. At times, policemen don't want to leave the suspect in the testing room. How do we deal with confidentiality and consent? Do we still need consent from the client? And what if the client declines for testing?
Okay, that's a good question. So in case it's a court order, the court order will come to the facility in charge. The law recognizes the DMOH or a facility in charge, whether it's a nurse or a clinical officer. And once it goes through, then the client is brought to you for testing. In this case, whether they decline or accept, it does not matter. Remember in the guidelines, we said in the first chapter, this is the only time you can test without.
Maybe we have lost you. We have lost you a bit.
In that case, giving consent won't matter. Whether they give consent or not, you will go ahead and test, and the results are handed over to the facility in charge, and they are taken to court. I didn't hear the question about the policeman. Maybe I missed that. I'm on the road.
Oh, okay, I can repeat the question. In some cases, perpetrators of rape and defilement are escorted by policemen for testing. While cases has not gone to the court, means there is no court order. At times, policemen don't want to leave suspects in the testing room. So there's actually no court order. How do we deal with the confidentiality and consent? Do we still need consent for the client, from this client? And
thank you. I heard you now. As long as there is no court order, do not go ahead and test. You must have the court order for you to test, and do not proceed to test on your own. Consult with the facility in charge, and if there is no court order, don't go ahead and test. We also have a lab in charge of the facility who needs to give guidance on this, but as long as there is no court order, you shouldn't test.
Okay. So I can go to the next question.
Yes, Collins, back to you.
What's the allowable attempt for following sexual partner? Since in line listing, book there are only 3 attempts, i.e., if the client continues to promise. That is, if the client continues to promise.
I'd like Anangwe or Talam to answer that question.
Sorry, Mary, just transitioning from the other question and answer session in another call. So just to look at the question again, what are the allowable attempts for following a sexual partner, since in the line listing book, there are only 3 attempts. I think there's no clear-cut guidance on this, but I would like to go back to our initial discussion in the opening sessions when Betty and Rose began the webinar, and we talked about the qualities of a good counselor right from the beginning. It's critical for us as HTS providers to ensure that we try to perfect those skills that are the requisite skills for providing routine HTS services, because then we are not just zeroing in on APNS per se, but generally the quality of the counseling services that we give. If for example, you're following up a client who keeps pushing forwards attempts to elicit contacts, then that tells you as a provider that something is amiss. And there is need to explore with this client why that is the case. I probably want to go back to our session on consenting. Did that properly happen? Informed consent. Did you actually, when you're offering an opportunity to this client to opt into APNS, was it an informed consent? Do they understand what APNS is? Are they satisfied by the fact that this is a safe and ethical service per se? Do they have concerns around APNS? So then that is an indicator or a red flag for you as a provider that there are concerns that this client has, and using the requisite skills as a good counselor, you should be able to explore and find out what the concerns this client has. One of the techniques that have worked well in practice have been brief motivational interviewing, where you guide the client using an informed set of questions to try and explore and identify their areas of concerns and address them moving forward. So it is important as a service provider to always look out for your client. Mary has just talked about intimate partner violence screening and the fact that safety in provision of index testing services and more or less APNS is really critical. And so, William, for this question, I would more want to zero in on aspects that will have been left out, especially early in the pre-testing session when information should have been given to this client, concerns that this client has should have been allayed, and this client should have been given a comfortable orientation to make an informed decision before they then opt into APNS. So I would refer you back to go and have a discussion with this client and try to find out the concerns that they have and address those concerns first before you even push forward with APNS. Thank you, and over.
Okay, so I'm finding that there are about 3 other questions which are remaining from the chats and also from the Q&A. So from the chats we have, can PNS be done to elicit clients from unlinked index clients from Scholastica? Then the other question is from Rose, how best can we explain to a couple that they are discordant in a situation where the negative partner has refused to use any protection, claiming they have been together for long and he or she is still negative? Then we have the last question, which is from Grace. Upon soliciting information for the index client and gave you consent to contact the sexual partner they had 5 years ago. However, the index client requests not to be quoted. Upon calling this partner, how do you then inform the index client if you found out the said partner is on care and in a clinic, bearing in mind the current partner or wife is negative? Kindly answer bearing the ethical issue. I think those are the 3 questions which were remaining. I think we can start with the first.
So I think, yes, I will answer the first one. Can PNS be done to elicited clients from unlinked index clients? Yes, this is possible, because for us linkage is when a client gets the CCC number, so it's okay, that can be done. The second one, how best can you explain to a couple that they are discordant in a situation where the negative partner has refused to use any protection, claiming that they have been together for long and he or she is still negative? So in times when you are having a couple, even before going to the testing, it's important to point out that the results can come 2 ways. They can both be positive, they can both be negative, or they can be discordant. That needs to be an expectation from the clients. So the role of the provider here is to make sure that they interpret the results as they come. So in terms of discordance, it's important to explain that, of course, considering the issues of the window period as well, that this person is negative and this other one is positive. And as long as they're continuing to have a sexual relationship, unprotected sex, the negative one can turn positive. Up to there, it is up to them what they do. Because I think sometimes the guilt that the provider carries is they thinking that what you're feeling, your empathy is what they are feeling according to them because of their relationship. There are many relationship dynamics that couples would want to continue having unprotected sex, even knowing that the other one is positive. Issues of the social issues, is it a woman? Is the man the provider? Yeah, are there issues of GBV? So couple testing and counseling doesn't have to end in one visit. You can go on having counseling sessions and try to speak to the couples even individually so that you can be able to send the message home. But remember, you'll not be able to save everyone. You can't save everyone, and you are not Jesus Christ. I think that is something that needs to be bottom line for counselors to know, that they do their best, but remember, by the end of the day, the couple will make their decisions either individually or together. Back to you, Collins. I didn't get the last one.
So the last question, I can read it again. It's a bit comprehensive. Upon soliciting information from the index client and gave you consent to contact the sexual partner they had 5 years ago. However, the index client requested not to be quoted. Upon calling the partner, who do you then inform the index client if you found out they say the partner is on care and in a clinic? So bearing in mind the current partner or wife is negative. Kindly answer bearing the ethical issue. So the question is just...
Anangwe, maybe if you understood that question better, please answer. In the road and having an issue understanding it. Yeah.
Okay, just Collins, do you mind just reading the question again? Sorry.
I can read the question again. Upon soliciting information from the index client, and you gave you consent to contact their sexual partner they had 5 years ago. However, the index client's request not to be quoted. Upon calling the partner, how do you then inform the index client if you found out the said partner is on care in a clinic? Bearing in mind the current partner or wife is negative. Kindly answer without bearing, kindly answer this bearing the ethical issue.
Thank you. Thank you. That's an interesting question. A good question again. So first of all, in index testing, in APNS, and I think for those of us who've gone through the critical NASCOP training curriculum and had the discussions that we normally have on a face-to-face discussion, some of these scenarios normally emanate during our trainings, and we respond to them. So confidentiality, and it takes me back to the first 2 weeks of the training, confidentiality. As a provider, you have got the moral obligation and the professional obligation as per the training standards to uphold confidentiality both ways, to the index client and to the contacts. And from our discussions, we always have trained our providers that when you elicit contacts from an index client and you reach out to the contacts using the approach as has been guided by the index client, because it's the index client who knows each and every elicited contact better than you, the provider. It is not ethical, and please allow me to emphasize on this call that it is not ethical for you to give a feedback loop of the details of the session you had with the contact to the index client. You protect the confidentiality.
Alanangwe, we have lost you.
I think he was talking about protecting the confidentiality of that client, that at no point should you be able to reveal the identity of that client. Confidentiality must be observed at all times. That's what he's saying. And that's what actually even in the training we talk about. And I think Dr. Talam talked about that. So for confidentiality, it's the cardinal rule in APNS. It must be observed. Back to you, Collins.
Okay, these questions are coming. There are many questions which are coming up. So I think I'll continue with the questions. So from Simon, From Simon, there is the issue of couples being sent for HIV test by pastors. Is it okay to test them and give them written results to take back to their pastor? Then the second question is from Techno.
Collins, can I take that one? Can I take that one? Because I keep forgetting when I take two. So the issue of pastors requesting and sending clients for testing, that is not allowed. You will have to get consent from the clients. Do they want to be tested or not? If not, don't test them. The pastor has no right to do that. Even for jobs, employment, and all that, it's not yet allowed for that. Back to you.
So, okay, the second question is from Techno, of 2. If you find out that the partner you are following is positive, do you go back and inform the index client?
Sorry, so the partner that you are following is positive. I thought the index client was already positive in the first place, because for APNS we are dealing with positives, right?
Yeah.
So at no point will you give the results of the partner. Remember, confidentiality, confidentiality, confidentiality. So what you find after that, remember you finished with your index, they gave you the partners. So going forward, you are the one giving results of the partners that you get going forward. So at no point are you going back to say, by the way, your name was given by A or B or C. No way. So it is your result. These are your results. If they consent again, you can get partners from them. And going forward, that is the system. But you can't divulge that information. Back to you, Collins.
Okay, we have another question. What is the best reason you can give to a client with an inconclusive result for more than 2 years and is not using any protection?
So inconclusive, that means a negative, I don't know. For 2 years, for the inconclusive results, I think we did that last week, and we talked about how the other tests are supposed to be done for confirmation. So I won't go back there. Maybe, Collins, what we can do is just share the notes so that those who missed out can be able to get the information. The final one, is it allowed for a client to take a picture of his or her results? It is up to them. Remember, those results are temporary. HIV results are never permanent, so they're just temporary. If the client wants to take, well, it's not something that we advise them to do, but remember, it is them, they are their results. I may not have a right or wrong answer for this one, but according to guidelines, we don't advocate for that. Back to you, Collins.
Yeah. Hi, Berry, this is Anangwe. Sorry, I dropped off due to my connection. If I may just emphasize a little on my response initially, that when on the question of how to message when eliciting contacts and giving a feedback loop after testing a contact back to the index client, I just want to summarize my response by saying that that is not ethical, and we should protect confidentiality both ways. Thank you, and over. Back to you. And sorry, I dropped off.
That's okay. So we have people from the audience who wanted to speak. So for Cornelius, I'll be allowing you, please be very fast. If you take more than 5 seconds, I move to the next person. So Cornelius. So we'll be moving to Vivian. Then we have Joyce. Then we have Paul. So if I've called your name, please, you can unmute your mic and start speaking.
Hello.
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 Okay, Paul, you can continue.
Hello.
Paul first, then Joyce. Paul, you can continue. Paul, we can't hear you. Trace, you can take over. Vivian? Okay, I'm not able to engage the audience, so I think we'll return back to the charts. So in the charts we have, for a case where one contact has been named by different index, how do you do APNS?
Collins, please just refresh. Sorry.
For, this question is been asked by Rebecca. For a case where one contact has been named by different indexes, how do you do APNS?
That's a very good question, and I want to thank the person who has asked that question, because these are scenarios that you're bound to experience in the field. So that defines for you a high-risk contact, and it begins to define to your concentration that fans out to a specific high-risk network. If you have one contact who has been elicited by multiple index clients, then it already gives you a direction towards this individual being involved in multiple networks, and therefore this is where we say that as providers, apart from just conducting APNS, you should also be able to use the information that you have to look at the networks that are emanating and try to work around. It can be more of a programmatic discussion that can elicit a package of preventive interventions around that population. So that's more of a programmatic question, because it elucidates towards as a network that emanates from one specific person who is really highly involved in high risk behavior, and by targeting that individual who is being elicited by multiple contacts, then empowering that individual and impacting that individual with an opportunity to know their HIV status, and if they are not infected, then really supporting them aggressively with combination prevention messaging and interventions. You then are working towards interrupting the transmission network around that individual, and also exploring the network around that individual. And I know there's a discussion around APNS, social network testing. This coalesce at some point, but that is a very interesting a finding that a provider or probably a program can be able to make and can inform targeted interventions that can help to break the chain of a transmission. So the critical step to take is, first of all, you need to reach out to that individual as you would reach out to any other contact based on the appropriate approach to offer testing, and then offer that person testing if they consent to it, and then establish their status, and then tailor make or probably offer appropriate services as per the HIV status. And also, for example, if they are HIV negative, then you really want to aggressively target that individual with a lot of HIV messaging, combination prevention messaging, and also explore the networks around that individual. Because then once you get a contact, then that contact becomes a secondary index. So it's important to speak to these questions, because they will occur as you implement APNS in the field. Thank you, and over.
Okay. So I think we still have like about 6 minutes to go. So I think I'll ask the remaining questions within the shortest time period, so that we can see whether we can address as many questions as possible. So from Damaris, how do you go about the case where a husband is positive and has given a wife, has given you a wife as a partner to test as a contact. Upon testing the wife, she turns negative, and the husband doesn't want to be tested as a couple in fear that the wife will leave the marriage and will rumor about his, and English is a bit complicated, but will rumor about his status. So can the wife be told of her husband's status, or the status of the husband be kept a secret from the wife?
Mary, are you able to take this one?
I may not have gotten it very correctly.
I can repeat it again.
The husband is positive.
So how do you go about a case where a husband is positive and has given you a wife as a partner to test as the contact, and upon testing the wife, she turns negative, and the husband doesn't want to be tested as a couple in fear that the wife will leave the marriage and will rumor about his status? So can the wife be told of the husband's status, or the status of the husband be kept a secret from the wife?
Okay, great. That's a very good question. So it's in case where the husband has tested individually, turns out positive, gives out the wife as a contact, she tests and she turns out negative. You will only give her her results. Remember, you tested her as an individual, so you'll only give her as a result, her results. It is important while you're doing the counseling not to divulge the results of her husband, because you remember you have confidentiality. There is no confidentiality you can have with one and not the other. It cuts across. If they wanted, they could have come and tested as a couple. So it's important that you explain to the wife that even if she's negative, the results of her partner or partners can be positive. So that's why it's important that they ensure that they know the results of the people they're having sex with. Remember, she has a responsibility of knowing the negativity or the positivity of her partners. Let's not take the burden of people and want to live their lives for them. They have a responsibility towards also living their lives. So it is important that she also brings her partner. It's for her to convince her partner to come in for testing. But I like that question. I know it's something that happens very commonly, and it's a burden that the provider is left with. Remember, if you tested them as an individual, you'll only give the results as an individual. But you may need to book that client, the positive one, more sessions so that you can teach them and give them skills on how to divulge their information on that they are positive to their partner, so that they can be able to support them. Remember, this guy will also get support. Some of them worry that their partners will leave them, and they actually never. If you look at some of the discordant couples we have, majority of the women who are negative still stay with partners who are positive. So that is how that should happen. Confidentiality must be observed. Back to you, Collins.
Okay, we have a question from Levi. I have a scenario whereby a child at 2 years tests positive, has TB and acute malnutrition. Can we commence ARV, anti-TBS, and address malnutrition at the same time?
I don't know if Dr. Julius is able to take that. Oh, Mary, go ahead.
Thank you. Let me go ahead. Thank you. I was talking and I was muted. So for that question, remember this is a HTS providers training. So I'll narrow it down to what the HTS provider needs to do. Give this client to the clinician. The clinician will be the best judge to know at what point do they start ARVs, what point do they start TBs, and to deal also with the malnutrition. It is not that compulsory that because you're a HTS provider, you must know everything that happens everywhere. The clinicians have been trained to know what they're going to start with. Of course, these are child who will need interventions, both TB, ARVs, and even the treatment for malnutrition will have to be done. Back to you, Nangwe, unless you want to. answer more. I think that's it from me. Back to you.
Thank you.
Nango and
Thank you.
Collins.
Thank you. That's correct. That's correct, Mary.
Okay. I think I'll try and speed up the last questions which I'll be asking. I think I'll take these last 3 questions. So my question is from Dorothy. Is when a client turns positive, agrees to be enrolled, and is willing to give out the contact of his/her treatment buddy at the CCC, and is not willing to speak out about the sexual contact, how do we go about it?
I can take that. And I know we've discussed this even in the previous sessions as we began today's discussion. APNS services should not be coercive. If a client is unwilling to elicit their contacts, then they should not be forced. And I think that's the guidance and the mentorship and the training that we continue to give. And even in the national guideline, in there we have the 7 principles of providing APNS services in the APNS guideline of 2019. And these services should be aligned to those 7 principles. So clients should not be forced to opt into APNS. But what we should do as providers is to provide these clients with adequate information to enable them to make an informed choice or an informed decision. Thank you, and over.
This is a question from Boniface. Is it possible to do a retest at home when the providers are 2?
Probably I can attempt, and Mary, from the policy standpoint, can back it up. Mary, if you're still there, I think the guideline stipulates, and it's very clear that retest should happen at facility level, and it's even stipulated within the national testing algorithm. So I would advise that we probably want to stick to that. But Mary, you're free to chime in if you'd like to indicate otherwise.
No. I support what you have said. The guidelines stipulate that confirmation should happen within health facilities. I think that could have been asked in the sense of self-testing. Self-testing can be done at home, but confirmation will always be done within health facilities, and that is clear within the guidelines. But we'll cover self-testing in the next session.
Thank you, Mary.
Linda, what do you do when a client cries during a session as you test?
Anango, just take that.
Okay, thank you. And I know as counselors we are taught to explore as we follow the HTS protocol. In the pre-testing session, we are trained to explore. When a client breaks down in a session, we are trained that we should be able to allow them to go through the process and provide first-line support to this client and explore the underlying causes of that episode. So that's what you should do as a client, and provide support to this. That's what you should do as a provider, to provide support to this client. Thank you, and over.
Okay, from William, we have, what's the allowable attempts for the following as a sexual partner? What's the allowable attempts for the following as a sexual partner, since in the line listing book, there are only 3 attempts? I think this question was answered earlier.
Yes, you're right. I actually spoke to that question earlier, but maybe to just paraphrase and summarize, is that there's no clear-cut guidance on how many attempts we should be able to make. But like indicated earlier in my submission to this question asked by someone else, if you see that an index client comes for visits at the facility and you try giving them an opportunity to elicit their contacts, and they keep pushing that forward, that means that there are underlying issues, there are concerns that needs to be addressed. And I spoke about a skill called brief motivational interviewing that counselors can be able to utilize to dig deeper and find out what the underlying causes are and address those causes. So as a client, as a counselor, you need to shift gears and look towards addressing the concerns or the underlying issues that this client has, that will either be able now to provide an informed standpoint to this client as to whether they will then proceed to elicit their contacts or they will opt out of APNS. Thank you, and over.
Okay, I think we have answered most of the questions. I think these questions are not ending, and I would like to end the session for today because we have already passed the 2 hours and 30 minutes mark. So I would request that for people who have joined in late during the middle of the session, you can go back to the YouTube, search the HTS Refresher Training. It's with the date for today. You'll be able to get the session for today, and it will be able to clarify most of the questions which were being asked. For the ones which we have not addressed, we'll be having another session on Wednesday next week. I think some of your questions can be answered then. I think I'll return back to Mary Megami to basically close the session.
Thank you, Collins, and I really appreciate the calmness and your patience and how you have run this call. Congratulations to you, Collins. And thank you, Anangwe, and the whole of the CDC team. On behalf of NASCOP, I want to thank all the participants who participated and congratulate you for wanting to know more. We can continue having more questions. I know we have had very many questions today because of APNS. It's a new strategy. Continue being curious to ask the questions, and we will purpose forever to continue giving you capacity building. A lot is going to be happening in the near future on APNS. We are working on the guidelines and some of the issues with policy, so we will keep you up to date. Thank you so much, and bye-bye.
Okay, bye-bye.
Thank you, bye.
Everyone. Bye-bye.
Mm-hmm.